Thanks everyone for joining us today. It's a pleasure to be here in my own living room, but I'd rather be with you all in a room, and hopefully we'll all be able to do that sometime in the near future. As Peggy pointed out, I'm Greg Shelley, the program manager for the Harris County Long-Term Care Ombudsman Program over at Cizik School of Nursing at UTHealth. As you can see from the first slide, there is a little bit of collaboration going on, just like for most programs. We are a organization that gets money through our Older Americans Act. We'll go into that in a little bit of history of the Ombudsman program, and I'll make that brief. But the state ombudsman in Austin distributes the funding to 28 different area agencies on aging across Texas. And ours happens to be over at the Area Agency on Aging in Harris County, which is funded by the Houston Health Department and Texas Health and Human Services Commission. And we have the great fortune of being one of the few contracted out programs. And in this case, we're the only one that's contracted to a university. And we get to spend time with the good folks over at Cizik School of Nursing at UTHealth. So we'll talk a little bit mostly about what the program is about. It'll be a bit of a whirlwind for you as I go through some basics about what the program is. I might interject an anecdote here and there, but I'm hoping to have some time for you at the end if you have some questions. And the good thing, a big part of what our program does in general, the uphill outreach issue, is making sure that folks know about us and are able to utilize us. That's the number one step. That's why we like doing these kinds of events. And anyone, for any reason, can call us and have a confidential conversation about anything related to long-term care. And we can't take any action on it unless you want us to. So basically, what is an ombudsman? If you look it up literally, you'll find that it says complaint investigator, sometimes very specifically. That's a small portion of what we actually do. We're advocates for the folks in the nursing homes and assisted living facilities. In some way, we are, oh, I had a little thing pop up there. We are just problem solvers, essentially, for the residents. Right. So I like to tell folks in kind of an elevator spiel, if you're looking to get somebody in trouble for something they're doing in a nursing home, then you should probably call long-term care regulation. If you're just trying to get a problem fixed on the ground there, the best place to start is with the Ombudsman program. And of course, if it ends up needing to be a regulatory issue, we can certainly coordinate and facilitate that process and maybe give you a better chance of getting to the kind of resolution that you're looking for. But we extend out from the residents themselves. Sometimes they can't speak for themselves. Sometimes we're the ones that are the eyes, ears, and voice for them. Sometimes it's legally authorized representatives, whether that's friends or family that help in the caregiving for the resident. A lot of what it's about is basically educating folks on their rights, their options, and what I like to say, giving good counsel based on our experience, making suggestions about what might be a good next course of action, and essentially trying to empower residents to be able to deal with things on their own. And usually that, knowledge is power. Once they learn that they have more rights than the rest of us under normal circumstances, they tend to be able to do a lot more on their own and want to do a lot more on their own without fear of retribution. And of course, in the bigger scheme of things, we're part of a network that has additional eyes and ears on the subject, generally on the residents and in the nursing homes and assisted livings here in the state of Texas. And that helps with reducing potential systemic abuse and neglect. A little bit of the history, we came out of the Older Americans Act shortly after the Older Americans Act kind of developed basically the current Medicaid, Medicare, and essentially the nursing home industry. It wasn't too long after that they decided a little additional oversight might be a good idea. The Ombudsman program ended up being in that part of the package. And you can see that it was not until 1978 that every state had Ombudsman programs functioning. Texas began to operate statewide in 1980 with the use of volunteers. And as you'll see later, volunteers are vital to this program in terms of outreach. We're very few in terms of staff. In 81, we had the assisted living care homes added. You see, it wasn't until 1999 that Texas itself started licensing assisted livings. And I wish I had time to discuss the difference between a licensed assisted living and the unlicensed homes, which way outnumber the licensed homes here in the state, especially here in Harris County. And then ombudsman statutes and two very important recent developments. The Texas legislature started providing additional funding for us to have more staff and cover assisted livings. With the vast number of assisted livings in Harris County, I got a slide later, but it's somewhere around 280 currently, that previously were, I guess, lucky if they saw an ombudsman in any given year. Now they see us at a minimum, regardless of size, at least 4 times a year, and more if they need us to come out and work on different issues. And then in 2016, a long-awaited final rule, which provided some very important defined guidelines on the Ombudsman program role. And part of that is the confidentiality and consent of the program. Anybody can call us with complaints or concerns, and we can't take any action on it unless the person wants us to. And generally our first step is going to be contacting the resident involved if it affects a particular resident and getting their consent to be involved in their business. Sometimes the person who called it in has a legitimate worry, and we can even verify it by our own vision, but the resident decides that it's not something they want us to mess with for a variety of reasons. And that keeps the power in their hands because it's their home, it's their place of living and their relationships. So in that role, a lot of times all we're doing is having a really solid conversation about rights and options and giving them some recommendations. But because we can't be there 24 hours, 7 days a week, we can't guarantee them that there's not going to be some form of retaliation, even though retaliation is against the law, right? But so we want them to have power. And of course, we run into situations where the individual can't give us consent. We'll touch base with that a little bit later. There are times when ombudsmen will generate complaints on their own. Consent is everything. Without it, we don't really have a case to work. I could spend 2 hours in a resident's room talking about all kinds of issues they're having. And if at the end of it, they say, Greg, I don't really want you to do anything. I can't really do anything, but I will let them know or ask for permission to touch base in another week or two and see if I can. And if something they tell me seems to be a systemic issue, something that affects a lot of residents in the building, generally what I'll do is say, hey, I'm gonna have conversations with other residents. And if one of them bring up a similar problem, I will let them be the person driving the complaint investigation. So we generally try to stay away from ombudsman generated complaints because I can go into any large, and by large, I mean 100+ bed, heavy Medicaid nursing home and find faults with it from my perspective. But my perspective isn't the key perspective, it's the resident's home. And for every resident that you find that might be upset about many different issues, a litany of issues, you'll likely find a resident who feels pretty comfortable and likes where they live and doesn't feel like getting anybody else involved. So one of the things that usually shocks folks to hear, and it really is an ombudsman myself, it took me years to get it into my head that this is fact. And that's what the final rule in 2016 helped define. We work off of federal rules and authority for the ombudsman program, which means we have to have the residents' consent or their legally authorized representatives to report even abuse, neglect, and exploitation. That gets messy sometimes because there's lots of things I would like to report. But on the other hand, when we're spending a lot of times in nursing homes, there's some stuff that the resident might not feel is all that bad in the nature of the relationship with their caregivers, but would qualify as a federal definition of verbal abuse, for instance. And I would hate to be in a position where we spend so much time in there and we suspect that that feels like verbal abuse and we had to report every one of those, we'd never get anything else done. And there might not be many caregivers left in a building. So the bigger part of that consent thing is it empowers them to have control over the situation. Just like you would have in an operational ombudsman setting, like an HR setting among staff, If you go to your manager and you say that somebody's harassing you, well, guess what? You've taken the control out of your manager's hands, and the manager has to legally report to the right people that there's a situation involving harassment, whether you want them to or not. On the other hand, if you're talking to an ombudsman, you get to find out what the options are, what your rights are, what likely outcomes are, and then you make an educated decision about what the next steps are. And so it's a hard one for us to get across, because there are situations where it seems like, man, I really want to report that. And I tell residents that I'd really love to help you with that. I feel like we could get it fixed for you, but it's their control. And fortunately to date, more often than not, by far, because folks knew they had that option, because they trusted us with it, either that day of the conversation or within a couple of days, they allowed us to report things to the proper folks. And we've had some serious issues, some involving sexual abuse by caregivers, that I feel like were only reported because the resident knew that they could confide in their ombudsman, and otherwise might not have told anyone because they were afraid of some kind of retaliation. Here's one also that a lot of providers don't realize, and really a lot of folks in general don't, that it is actually a Class B misdemeanor to interfere with us. And the interference has a variety of forms. Sometimes it's a staff member telling somebody that they can't talk to the ombudsman. Sometimes it's intentionally taking down our mandatory notifications in the building. Sometimes it's refusing to give us information that we're entitled to. But it does have the legal authority and not just regulatory authority. So currently every county in the country, including DC and Puerto Rico, have representation. And if you contacted any of the Ombudsman program, we'd be able to get you in touch with any other program across the country. Ours is the only one housed in a university, as I mentioned before. That has many benefits for us as individual professionals, but also the outreach of the program. And we get to work with all the lovely folks over at Cizik School of Nursing, which is something I am very proud of. Harris County has 103 nursing facilities and 281 licensed assisted living facilities currently. The number of assisted livings has dropped off since COVID-19 came into our lives. That is mostly folks opting to discharge residents to other places and deciding not to operate for the safety of everyone. That's generally the smaller ones, the residential type settings. Prior to that, we had been going up by, I would say we get a new assisted living every couple of months. And we were up to 297 before COVID came. Still a large number of them to be covered. And we have just 8 staff members. And normally we've been operating at 7 staff members, but some of the CARES Act funds came to us to help us deal with the issues involving the pandemic. So we were happy to be able to add an 8th staff member. Of course, that stretch is pretty significant. And so the volunteers really are the driving force when it comes to qualitative visits and coverage of nursing homes in particular. They typically make a visit a week and spend about 2 hours on average. And they're building qualitative relationships. Like I say, you know, even ombudsman just goes in and meets one new resident and learns a whole lot about a situation. Even if they don't get to help, that's a really good ombudsman day. Other days, seems like nobody really wants to talk beyond the greeting and finding out what you do. And you end up, you know, telling 15, 16 people about the ombudsman program. And so they know they have options and places to go. That's an important part of it as well. But the staff gets kind of stretched, and we end up doing speed rounds or sometimes going to nursing homes for a specific complaint. And we don't typically get to spend a great deal of time in any one facility building those relationships in the way we would like to. So some of our goals, this is just a short list of them, but of course we want to educate residents, families, friends, really the entire public about us and about the fact that nursing home residents pre-pandemic and hopefully post-pandemic have more rights than the rest of us do in our own residential care settings. We want to educate caregivers And sometimes that's staff in servicing, and sometimes it's public presentations like this. Sometimes it's printed material just about the Ombudsman program and about rights. We do get a number of calls from staff because the ones that really know our role understand that they can call us anonymously. They don't even have to tell us their name. They don't have to tell us their role. They can just let us know they have concerns about a particular resident. And our first goal is going to go meet that resident and see what we can do to help them. And then they don't have to give up their identification and risk getting in trouble at their job. We empower residents through the exercise of their rights. You know, a lot of residents are afraid they're going to get kicked out of a nursing home if they complain, if they exercise their right to complain. The truth is, some of the sturdiest rights they have are the defense of an attempt to involuntarily discharge a resident. And the ombudsmen are very good at helping with that. And once a resident understands that they have those rights, they have a greater tendency to want to exercise their other rights, including complaining about situations of their own care, and on a greater level, complaining about situations that may be systemic and potentially could improve the environment for everyone living there. We provide information regarding where to go to get care and how to get quality care. So folks that are ahead of the curve and are looking way in advance of needing long-term care, we're a good place to start. We've got lots of information we can provide for reading purposes. We have current list of every facility in our county. We have ombudsmen who visit those places and can give you individual insight about characteristics of a place that might be a better fit for you that you're unlikely to find anywhere else. And ultimately, the education and outreach extends to all kinds of public education, media interviews, sending out flyers, handing out pamphlets, you name it. The uphill battle continues. The average person that I say I'm an ombudsman to, even if I'm in a nursing home, they kind of roll their eyes back in their head and don't know what I'm talking about. And they've never met one because we're very few. So spreading the word is very helpful, and advocating on the higher scheme of things, actually advocating for positive changes to any legislation affecting long-term care and residents. And that comes into play a little bit later. We'll talk about worrisome cuts to things that might cause additional problems. But to give you a little scale, Harris County alone has over 10,000 residents in nursing homes. We're not even talking about the 281 assisted livings there. Texas Health and Human Services is called long-term care regulation now. Used to be called regulatory. Prior to that, used to be called DADS affectionately, Department of Aging and Disability Services, but it's currently under long-term care regulation within Health and Human Services. Of course, the Ombudsman program, we're advocacy in general, additional eyes and ears. You know, one of the things about advocacy is sometimes the certified nursing assistants, which I like to say are the least paid, endure the most grief, and do a lot of the majority of the direct caregiving in a nursing home, right? They'll say, well, who's advocating for me? I've said, well, we actually advocate for changes to the industry practices that should be helpful to them, including we would like for many of them to be on a higher pay scale than they currently are, because staff turnover, as we'll touch base on later, is a key driver of poor quality outcomes for both the folks working there and the residents they care for, right? So, and the consistent assignment idea, right? How nice it is to be able to care for the same set of residents on a regular basis. And how nice is it for the residents to have those same caregivers caring for them, because they're more likely to know their individual needs than someone who's coming in on a shift last second to cover and has no idea about the people that they're about to care for over the next 8 hours. And of course, you know, sometimes we even experience feelings of futility. I've stood in the middle of some large nursing homes and literally cried over things I had seen or people in need, and that's for both the CNAs and the residents themselves over different situations. And I always tell my staff and the volunteers that all we can do is one person, one case at a time. And that keeps me going. And any idea of, you know, to say, well, we couldn't fix a problem. And there's some problems we can't fix. It's just reality. You know, by removing us, I don't think things are going to get better. And I think it is an important part of what happens, that there needs to be oversight of especially the nursing home settings. And, you know, it's unfair. A lot of times when I'm talking, people get the idea that it's all negative stuff. There's a huge spectrum of long-term care. The assisted living is the biggest spectrum. And you got everything from a 4-person house in residential neighborhood all the way up to, you know, 180 bed apartment style living, some quite luxurious. And nursing homes, you've got a spread from a 30 bed nursing home all the way up to 200 plus and 90% Medicaid. Those are different environments for sure, both from a business standpoint and a caregiving standpoint. So, but time is brief, so we sometimes have to talk in generalities, and I try not to hurt any feelings when I do that. So threats to quality and long-term care, some of the key ones, cutting the regulatory agencies on state or federal is always opens a can of worms. Less oversight would be difficult. Now, I feel for some of the facilities in terms of red tape when it comes to some of the way the rules are written. And I agree that some of the rules could be better written to both allow for efficiency and good care. But I am not a fan of cutting any of the rules in terms of making it less or having fewer visits. An example of that is 1 year, it's been a while, I've lost track of the chronology there, but at one point, long-term care regulatory had enough folks to be able to do an annual survey once a year of all the assisted living facilities. But that got cut, and now they're on the every other year. So some of these assisted livings, other than the quarterly ombudsman visit, don't even see a regulatory person except every 2 years. That's not a lot of oversight. Of course, cuts to Medicaid and Medicare. Medicare, because of the skilled nursing side, it's the big money side of the business. It funded a lot of changes to older nursing homes who are, you know, trying to bring in that part of the business, skilled nursing therapy, short-term side of it. So if you cut that, you're just going to impact the bottom line of nursing homes. And like a lot of businesses, if they lose money, generally they're going to try to make it up through the most expensive part of what they do, and that's cutting staffing. The same with Medicaid. If you cut Medicaid, the profit margin for the heavy Medicaid facilities is already pretty low. No one's ever opened their books to me to show me, so I don't shed a whole lot of tears. I assume most of them are making a profit. But if you wanted an example in Harris County, we had a couple of relatively welcomed smaller nursing homes that had been in the communities for a long time. And so a lot of their residents and their caregivers were from the immediate neighborhood. But they were both Medicaid only facilities. And in the modern world, that business model did not work out well. Both of them ended up in bankruptcy within the last, I think it's within the last 8 years. So that tells me that yes, operating in a full Medicaid environment or a heavy Medicaid environment is certainly challenging. And so if they were to take away money from those places, I would assume they're probably going to cut staff as well. And that's certainly not going to make things better. That's where we get into the inadequate staffing issue. A lot of folks are shocked. They go into some nursing homes and they like, hey, there's like 100 people here and I only see 3 CNAs. And they want to know what the staffing ratio rules are. And then if they ask an ombudsman, they'll find out that there's not much specific staff ratio requirements in the current regulations. It's 0.4 nursing hours per resident per day. So if you had 100 residents in a nursing home, if you have 5 8-hour shifts of nurses, that can be RNs, LVNs. So all you need is 5 shifts over the course of 24 hours and you've covered that minimum requirement. I'd say fortunately in my experience, I've never seen anybody come close to that minimum. Most facilities make it up in the very first shift of nurses. But it is at least a standard, I suppose. but everybody's kind of shocked that the certified nursing assistant who does the majority of direct care is not mentioned in that staffing role at all, unless the facilities take the great pains to become a certified Alzheimer's unit. And I'm trying to think, make sure I say the right thing. There's only 3 left in Harris County. Those come with additional requirements of staffing ratios and training, dementia-based training specific for caregivers. So some common problems that we deal with or we find very often from the consumer side, or at least family side: arbitration agreements. Facilities are not supposed to include that in admissions agreement as a condition of care. They're not supposed to say, if you don't sign this, we're not going to give you care here. Because what an arbitration agreement is an opportunity for an individual to sign away their right to future litigation. So basically they're saying, I won't sue you. I will agree to have everything arbitrated here. And just because it's one of their rights is one of the things we push back on, because we would like them to know that they don't have to sign it. If they do it willingly and knowledgefully, then that's their business. But one of the bigger things is historically, big changes to nursing home care have come as a result of litigation and the legislation that followed those lawsuits. It's been a while since any big ones hit. And truthfully, if you looked at nursing home care in the 80s versus where it is today, you would say it's come a long way. Still got a long ways to go. Admission, transfer, and discharge. That is probably the most conflict-driven piece that we deal with, and we deal with it on a regular basis. There are some acceptable reasons for which a nursing home can involuntarily discharge a resident. But the resident still has rights, and the facility still has responsibility for making sure any discharge is ultimately a safe discharge. And so there's a lot of process and rules that have to follow out. Residents have the right to appeal a 30-day discharge notice, for instance, even in cases of non-payment. And a lot of folks from the outside, they look and go, well, the facilities have a right to get paid. I want the facilities to get paid, because if they don't, we're all in bad shape. But sometimes folks come in situations where they don't have benefits. They're not connected to Medicaid already. And these are things that very often you can tell right up front when a person comes in, whether it's under Medicare or whether it's on a letter of agreement from a hospital. And we should go to work day one on getting them connected to the benefits they need for whatever their future care situation is. But unfortunately, in the chaos of things, it doesn't happen all that often. And so, of course, a month later, when the facility is not getting paid, they're looking to take action on it. And first thing that comes to mind is, you got to go. Well, there's a lot of other options in between. And I just wish very often that we could get involved sooner rather than later and try to help them get connected to the benefits that they deserve. Lack of individualized care. That's a tough one. I mean, can you imagine the task and the challenges of caring for 180 people in a nursing home and giving them all unique, idiosyncratic, individualized care? It would be virtually impossible if everybody was demanding the same thing at the very same time. It's very difficult. Doesn't change the fact that the residents have a right to that individualized care, and the care planning should spell it out. The good thing is, when you have a group of 180 residents, you generally find some that are willing to be tolerant of the situation and acknowledge that they can't do everything right this moment for everybody. But one of my favorite arguments is when somebody gets upset, because it does seem like a big task. I got to do this individualized stuff for 180 folks. Let's say this resident wants hot sauce on their food and their doctor's saying they're going to get heartburn. Well, they have a right to go against medical advice, one, just like you and I do. And two, we could put that into the care plan and document it so the facility's not getting in trouble for giving the resident heartburn. Those kinds of things are solvable. It just comes with a fair amount of work. And in fairness to everybody who works in nursing home, it is busy and they are stretched thin, and it is a huge challenge in front of them all. Low staffing, high turnover. Look at that. I don't know if you can see the graphic very well, but the annual staff turnover in Texas in nursing homes is one of the highest in the country. That is an underlying systemic issue that leads to all kinds of problems. I mean, it doesn't make the workplace a great place to work in. And you can imagine the effects of what that means on care. And it's not just the certified nursing assistants, it's at all levels. And you know, it's not all that uncommon for some of these large Medicaid facilities to have a different administrator 4 times in the same year. And that is certainly affects the outlook of everybody who reports to them. And you see there, 90% on average across the whole state of registered nurses turnover in long-term care in nursing homes, and 90% of vocational nurses. Look at the certified nursing assistants, 97%. From my old history as an operations manager, that tells me something is wrong about the workplace, right? Either if you had that in like a for-profit business and you're supposed to produce stuff and 97% of your key workforce is turning over, what do? You've got to pay them more. You got to give them a better working environment. All these things need to change, but it's not so easy to do in the nursing home environment because, you know, they got a bottom line too, and it's not necessarily all about the profit side for every one of them. Ignorance. I know when I was younger, I had such a negative connotation about someone calling me ignorant. Now I have a better understanding and I gladly call myself ignorant. One of my daily tasks is to be a little less ignorant by the time the next day is over. And that's really just innocently, it's one of the things. Outreach to getting training to some of the certified nursing assistants is difficult. It's not like facilities have a ton of money where they can just say, okay, why don't you take the day off and we're going to pay you for it. And we're also going to pay you for training. It's hard enough to be able to get in there and take an hour time from the CNAs and some of the LVNs, et cetera. And the facility's got to pay for it. And the administrator's under great pressure to, you know, manage that bottom line, of course. And so it's difficult. And it's hard when you provide that training. Sometimes it's hard to show the direct results, even though, you know, I think most of us that do any kind of side learning, we know there's results, though it's sometimes hard to show empirically. And that makes it harder to spend the money on it. This is some of the challenges they're dealing with. I think pretty much the general public associates nursing homes with folks with dementia. That's just a small part of it. The other thing is when we talk about ignorance, most folks don't understand that Alzheimer's, for instance, is just one type of dementia. It's under the umbrella. And then you get down to the fact that we lose sight of this. We'll say, well, that person has Alzheimer's or that person has dementia. And we assume that everybody that has dementia is the same. And that's just simply unfair. Everybody has different backgrounds. Everybody has different genetics. Everybody has different histories. And so those diseases affect them differently. Not everybody that has dementia, and this is the one I've seen more often than not, they'll be right there in the room with me and the person say, well, they have a dementia. How can they make that decision? And there's so many different levels of dementia that just seems absurd to me now because I understand it from a little bit more informed level. So that's part of the problem for all of us systemically. And sometimes I say, folks will say, well, Greg, how did we get this way when they see something bad in a nursing home? How did we get here? And I've gotten to the level that I can't blame the people right in front of me always. It's not that simple. I can't blame the nursing home. I can't blame the nursing home industry. It is our collective culture that allows things to be the way they are. And unfortunately, human nature tends to be, if it doesn't affect me or mine, it's not that big of a deal. So unfortunately, more and more of this is affecting more and more people, and we're getting more attention on some of the underlying issues. But it involves working together. Everybody needs to work together to try to change it. I mean, the other thing that people don't see a lot on the outside is how many mental health issues are being dealt with in the nursing home. In Harris County, it seems almost like you've got homeless, you've got the jail, and then you've got secure units in nursing homes where you have sometimes folks who have schizophrenia and folks who have dementia gathered together and being treated kind of singularly. So you can imagine the problems that might create, especially if folks aren't getting let's say, medication on the exact time frame that they're supposed to be. And that's a common issue as well. And then you've got all kinds of chronic disease. I was going to touch base about this part on aging and ageism in COVID-19 times. It's really been exposed in our culture in a just terribly upsetting way. It's bad enough as it is on a normal day pre-pandemic, but this notion that I'll start with the underlying condition stuff. Folks, adults in the US, according to CDC, for instance, 2/3 of every adult in the US have some underlying condition. That means everyone over the age of 18. Once you get to 50, and I'm 52, and I'm learning fast, things start to break down. And you suddenly either get an underlying condition or you're on different medications. It's rare for folks over the age of 50 to not have some kind of underlying condition. Even rarer when you get over the age of 65. So all those folks are much more susceptible to something like COVID-19 and bad outcomes. And then you've got this idea that just because 40% of the folks dying of COVID are dying in nursing homes, somehow that these folks were going to die anyway. That just enrages me because it's personal to me. I lost my neighbor across the street who ran his own business and probably was going to live 20 more years based on his family history. He died of COVID. He got sick. 3 days later, he's on his way to the hospital. As the last time I got to say bye to him, 8 days later, he was dead. I had a nursing home resident that I worked with over a discharge case and became really close to. And I would say is a friend back and forth. She was 3 months younger than me. And she got COVID and died. And there was no indication she was going to be going anywhere in the next decade at least. So don't get me started on that subject. It's just not fair. The other part is the rules of confinement for nursing home residents. Nobody came up to you and told you that you couldn't have visitors in your home or that you couldn't leave the building. Well, that's what happened to residents back in March here in this state. And I would say in Texas, we were kind of fortunate that we did it at the time we did. And we had a little bit of forewarning coming from the upper Northwest coast and upper Northeast coast, which gave our leadership some knowledge that, yeah, this looks real and maybe we should shut down. But then the problem was, it wasn't until really just about 2 months ago that we finally changed those rules and made them different. So now every nursing home and assisted living has mandatory essential caregiver visits, something that wasn't in place before, and is one of the restoration of rights. But even when we're talking about holiday, trying to get a resident to be able to go have a meal with their family, often they're facing consequences. They're being told they have to isolate for the next 14 days when they return. And when that is technically not true for everybody currently, thanks to the emergency order from the governor, it's still being treated that way. So things are coming across as very institutional under the guise of safety. And when you think about folks as individuals, that's the interesting thing that we forget about. Not everybody in a nursing home wants to be locked down and protected. On the other hand, my first visit back in September to a facility that had no COVID in it at the time, but had gone through a phase with it, the residents there were just happy that they could commune in a general area together and have their own company. And they preferred not having visitors, interestingly enough, because they didn't want to be exposed to it. But that's just the uniqueness of the individual that gets lost sometimes in that kind of institutionalized care. The other thing that gets passed on a lot is informed consent. Seen plenty of cases of folks being given medication for the treatment of COVID and other things without being explained what the potential consequences and outcomes are. They don't get informed consent when someone says, you just need this, here, take it. The same applies to what was going on pre-pandemic with some of the psychotropic medications, where the folks were being told to take it and not being given options, or not being told potentially very bad consequences of doing it. Nursing homes, assisted living, we saw, especially in this area, the worst of it we saw back in the peak of June, when about 95% of our nursing homes had outbreaks. We were going in a really good direction. We were down to about 28%. Currently, we're sitting at about 60%. That's been a basically weekly uptick ever since late October. And based on what I'm hearing, I'm afraid it's going to get worse because it tends to reflect what's going on in the community. Naturally, caregivers are coming and going. If they get exposed to it in the community, they're more likely to bring it into the nursing homes. But assisted livings, as we've learned, because more of them have private rooms, bigger spaces, truthfully, they don't have the same kind of typical medical needs that are being taken care of. So you don't have like a nurse or CNA in close proximity to you for a long period of time in a closed space, right? But that's something that I'm hoping will lead, I think we all are hoping will lead to some changes in care in the future. There's some really good models, the Eden Care for nursing homes, where they kind of make it a campus and you have multiple buildings on there, and you're able to kind of segregate folks based on needs and abilities, and it makes it a smaller, more, I don't know, homey community, if you will. And folks do forget that living in a nursing home and assisted living facility is a residence. It's residential long-term care. So they have the same rights and more typically than we do living in our own home residence, although it's often, stepped on. So a couple of things for consumers in general, outside of calling the Ombudsman program and talking about your facilities. Nursing Home Compare really is the best place to go and get key information on nursing homes. It'll allow you to compare staffing levels in nursing homes, one to the other locally. It'll allow you to read all of the latest results from the recent surveys and complaint investigations. It'll allow you to look at a 5-star key and get some idea. I mean, I think the average person, if they saw a 1-star facility versus a 5-star facility and they didn't know anything else, they'd probably play the insurance odds on that. But it's just one way for consumers to get educated. You can see similar information on Texas Health and Human Services on their long-term care search. Unfortunately, there's no rating system for assisted livings, and assisted livings are only regulated by state law and not by federal law. So you would struggle, but you can find them on the long-term care search and at least see if there were any recent citations against them. So I think for assisted living these days, and really for nursing homes, a good place to get information more and more. It's growing, and we need a bigger database. But Yelp and Google reviews, if you kind of throw out, you can, if they got like 50 or more reviews and they're kind of recent, you can kind of throw out the ones where people were incredibly upset and had lost their mind over something. And then the ones where they're like overly gloating about how wonderful the place was. You might raise your eyebrows to those two, but everything in the middle would give you a pretty good indication and help you make a decision between one or the other. That's something that's coming along. It's not where I'd like to have it at, but the folks at ProPublica have added fines and things that nursing homes have gotten on the Yelp site too. So it's a quick glance at some of this stuff. And it's a good one to have questions. You write down your questions about that. And then you talk to the Ombudsman about what's happening there. Who knows? There might have been a leadership change recently. Maybe they've gone through a whole renovation and fixed some things in the last 6 months. The Ombudsman will be able to tell you whether or not it seems to be a really institutional leaning place or one that's really responsive. And I like the responsive ones myself. I prefer that. So there's our current staff team and the way that we currently do our meetings. Hi, staff. It has become a kind of an efficient way to do things, but we sure miss being able to be together. And we aren't making regular visits, but we are visiting nursing homes and assisted living, but just not nearly in the quantity that we used to. We are doing far more telephone, FaceTime, WebEx type information and assistance and consultations. Our casework continues to go. It's just harder to get some information sometimes. It may take a little longer, where if I'm in a nursing home, I can go find a social worker and talk to them at that moment. If I'm calling over the phone, it may take a while to get the answer I need. But the work goes on, that's for sure. And we do make visits where needed. And we try, because we don't ever want to be somebody who's spreading any kind of infection. So under normal operations, if we're not feeling well, or if the facility is having some kind of viral outbreak, we don't visit during those times, because by the nature of being an ombudsman, you go from person to person to person, and we don't want to do that. But we have done indoor visits, and we will where necessary. Typically, we're doing them where well, at least as far as we know, there's no COVID in the building. But we do still have the legal authority to visit both nursing homes and assisted living facilities. So a lot of things that we help with: choosing homes. How do I get good care when I'm there? We talk about care planning in nursing homes. That's key. Service planning in assisted livings. Key thing, money follows the person. A lot of folks living in nursing homes under Medicaid don't realize they have less restrictive options in assisted living, even independent living. And one of my favorite success stories, a woman living with dementia who had been bounced around from nursing home to nursing home for several years before her daughter ran into an ombudsman and explained the Money Follows the Person program. And she was able to take her home and have the care covered and be able to be the support and the primary caregiver there at home for the last part of her life. More people need to know about that program, and people that get skeptical, you know, like government skeptical and anti-tax, it's good for everybody because the person gets in a better placement, and naturally it costs less to provide care in those settings for Medicaid and the system than it does for care in a nursing home. So if you're interested in volunteering, we have a long training course. It's free. Except for your time and energy. Those are very expensive things. We can't pay you back for them except for the rewarding experience as a certified ombudsman. Typically, ombudsmen visit a facility every week for a couple of hours. We ask that if you join the program, because we put so much time into the training, that you spend at least 1 year with us. I'm proud to say that at last check, we had over 26 volunteers who've been with us for more than 5 years. We have 3 that are right around the 20-year mark right now. And the longest serving ombudsman that we had was Ellen McDonald, who finally retired after 25 years to spend more time taking care of herself. And then, so our training normally is 2 classroom trainings and then a couple of placement visits. We're not doing those during this time, so it's an easier time to be able to get the training in. It's the 12 hours of classroom training is broken up over 6 WebEx meetings over the course of 6 straight weeks, beginning January 21st, the next class. So you can get fully certified now as ombudsman virtually over the course of 60 days. And you can start doing FaceTime, you could do staff in service, you can do information and assistance, you can do care and comfort calls to facilities, all basic ombudsman work. And if you really wanted to, you could start visiting a nursing home. Right now, we are requiring everyone to be tested every 2 weeks for COVID. And we would cover the cost if somebody wanted to do that. Otherwise, they won't be allowed to visit. Of course, indoor visits, we are N95 fit tested and wear at least N95s and a face mask. But depending on the individual facility protocol, we'll accommodate folks who decided not to get tested for COVID. Will be required any visit to wear full set of PPE, whether it's an outdoor or indoor visit. One of our greatest fears is to be somebody that brings that nasty virus into one of the nursing homes, you know, the most vulnerable population, and it's so easy to spread within a building. Let's see. So some more information, it's on the presentation and PDF form if you want to check those things out. If you got social media, lots of good information on our YouTube channel. We'd love to have you a part of that. Here's my information. If you have just a general ombudsman question, I'd encourage you, you probably get a faster response if you use the information for the ombudsman in the 9931. But if you wanted to talk to me personally, you're certainly welcome to. There's my contact information. I say thank you very much for the time. I think we still have a few minutes. If there's any questions there, I'll be happy to take them, Peggy. And part of what I was saying before was that if folks had questions that go beyond this time frame, give us a call. Consultations don't cost you anything, and it's what we do. That's what we're there for. And we're happy to talk about a wide range of subjects. Heck, we even get people asking where certain clinics are. And while it's not our job, if we happen to be in front of a Google map, we'll find it for them and tell them. So